Hello. Today, we will continue our lectures regarding the primary headache syndrome. We have already discussed two important types of primary headache syndrome. Those are the migraine and the tension type headache. Now, today we will discuss about the trigeminal autonomic cephalgia, the headache that is a bit different from the previous two types. If you want to consider the types of trigeminal autonomic cephalgia, there are 5 types. One is the cluster headache. Then we will, assort the rest 4 headache in 2 groups. One group is hemicrania, that means paroxysmal hemicrania and hemicrania continua. There will be a bit similarities when we are going to read these 2 types of headache. And another 2 is the sanct and suna, that is the short-lasting unilateral neuralgia from headache with conjunctival injection and tearing. Another one is short-lasting unilateral neuralgia from headache with cranial autonomic symptoms. So, let's dig in. First, the most important headache is the cluster headache. That is very important. That if you want to study regarding the trigeminal autonomic cephalgia, you need to understand all these types of headache will be strictly unilateral. And in case of trigeminal autonomic cephalgia, apart from being unilateral, all of those headache will be having some trigeminal autonomic symptoms. The autonomic symptoms are mostly parasympathomimetic. Okay, so all these sorts of headache, we are going to expect some autonomic manifestations. That is the most important part. And the rest classification will be on difference according to the treatment response, that which drug will work in this way. Second thing is that the duration of headache and particularly the frequency of headache. That is the most important part. So if you start, the cluster headache is the first one. That is strictly unilateral in the first point. Second thing is that the headache that lasts between 15 minutes to 3 hours. That is very important. So it is the headache that lasting from almost 15 minutes to 3 hours. And the headache that there will be always some conjunctival symptom, that is the autonomic features. You can get a lot of things like the conjunctival injection, lacrimation, meiosis, ptosis. All these things is due to temporarily sympathetic blockage, that is the Horner syndrome. So you will get a Horner syndrome in some attack. Second thing is that there could be eyelid edema, rhinorrhea, nasal blockage, or facial swelling, or particularly sweating. These are the more in features with autonomic syndrome. There will be some parasympathomimetic action, there will be some sympatholytic action. These features will present in all sorts of trigeminal in autonomic cephalgia. Okay, so if you want to study the cluster headache, first thing is that it is strictly unilateral. Second thing is that there will be autonomic features. Third thing is that the headache will last from approximately 15 minutes to 3 hours. Fourth thing is that the headache that will be a very few frequency in a day. Like if you want to study the frequency, we can check that a cluster headache can present on every alternate day to almost sometimes 8 times in a day. So the cluster headache can present only one episode in particularly 2 days to sometimes at least 8 episodes highest in a day. That is the most important part. So the cluster headache in the mostly time, it will occur 1 to 2 times per day. And that will be having a striking circadian rhythmicity. Sometimes in some individual, the cluster headache will occur every day on 7 to 8 p.m. That is the first particular thing. So there will be striking circadian rhythmicity. And sometimes there could be some precipitor, particularly you should always remember alcoholism and also sometimes exercise and volatile substance. So if you want to understand cluster headache, we should know that cluster headache actually occurs in a particular cluster. What is particular cluster? That is, if we know the periodicity, in maximum cases there will be an episodic cluster headache. Like if the cluster headache present, it will persist for about 1 week. Then patient will have a remission of approximately 4 weeks. This is an episodic cluster headache. This is the most important type. And sometimes if the patient having chronic cluster headache or CCH, there will be a particular headache duration of 1 year with no remission in between. Okay, or if there is any remission, the remission must be less than 1 month. So that is not strictly we need to know. The most important thing you need to know that there will be a cluster. Like, you know, there will be a zone of time. This is one cluster. Suppose this is another cluster. This is another cluster. So we can say this is cluster 1. This is cluster 2. And in between the class 2 cluster, there will be a cluster free period of time. In that period, there will be no headache. Okay, so what can we understand? Okay, so there will be a period of cluster headache, then period of no headache, then period of cluster headache. When in particular duration of 1 week to sometimes 1 year, okay, the cluster headache will occur in most of the time a certain time. So that is called the circadian rhythm. So in between the 1 week to 1 year, that is the cluster headache period, there it will follow a typical circadian rhythm. Okay, so in the most of the days, in 1 week to 1 year, at the time the patient will be having cluster headache, the headache will last for approximately 15 minutes to almost 3 hours, persisting in 1 to 2 episodes in a day. In the most of the time, there could be extend up to 8 episodes in a day. So if a patient came to you with having a typical headache, that headache is strictly confining to right part of the head. Second thing is that he also complaining there will be some ptosis, also myosis involving the right eye and eyelid. Also, there will be conjunctival congestion, tearing involving the right side of the face, particularly involving the ophthalmic region of the trigeminal nerve. And he said that whenever the headaches come, it persists for approximately in a 15 minutes to 3 hours. Second thing is that, and this headache, this is the time duration, but this headache persists for about 3 hours, but occurring approximately 1 to 2 episodes in a day. And he said that whenever this episodes continues, it continues for about particularly 1 month. This could be a features of cluster headache. And after that 1 month, he will be having a period of 1 year or 2 months of having any cluster-free episode. So there will be cluster headache episode, and the headache episode will be lasting for approximately 1 week to 1 year, depending upon the causes. After that, there will be a period of no headache. And after that period, there will be again a period of cluster headache. Okay, that will be lasting for 1 week to 1 year. That is the particular presentation of cluster headache. During the time of cluster, that means that during the time of this headache, there could be a circadian manifestation. There could be a headache that lasting approximately 15 minutes to 3 hours with autonomic features, or there will be an episode that may be in the every alternate day, or sometimes in the worst cases, 8 episodes in a day. So that is typical cluster headache. Okay, so we need to know the triggering of cluster headache. That is the most important triggering for MRCP exam. That is the alcohol. Sometimes exercise or volatile substance are also important. In 80 to 90% cases, there will be episodic cluster headache that lasting for a duration of more than 1 week, and that is separated for a remission that lasting for more than 4 weeks. And the remaining one will be the chronic cluster headache. And sometimes you also need to remember a striking circannual periodicity, that sometimes in a year, the cluster could be occurring in the same time in a month. In some cases, every time the patient complains that I having these sorts of headache every March in a year, particularly that lasting for March to April. So you need to know this interesting fact regarding the cluster headache. Okay, so now how we will manage a case of cluster headache? We should know 2 things. there is a role of oxygen, particularly 100% oxygen, that we should give in a 7 to 12 liter per minute. And sometimes this is a very good efficacy, and sometimes we can also use subcutaneous sumatriptan or maybe zolmitriptan. Okay, so two drugs having particular very important, one of is oxygen, and another thing is the subcutaneous sumatriptan. Now, in order, this is the treatment we should give during the time of cluster episode. So after that, after complaining of completion of cluster episode for approximately 1 month or 2 months or something like that, then the patient will be having a cluster free episode. So we need to check that patient won't having these symptoms again. So there will be some preventive treatment. So we can give verapamil. Okay, so verapamil will be the choice of drug in particularly all episodic cluster headache or chronic cluster headache. Before giving verapamil, we should check the ECG, because the verapamil having a very bad effect on the heart in sometimes, particularly having heart block. If a patient having heart block previously or any condition that could be deteriorated by giving verapamil, we should check that. So verapamil is also a very good anti-arrhythmic drug. In a patient, particularly having heart block, we should check a baseline ECG before giving verapamil. So verapamil is the drug of choice for cluster headache prevention. Now, there is other treatment option like lithium, methyl sagride, okay, topiramate or sodium valproate, but these are not that much important like of verapamil. So there is some surgical manifestation as well, because the issue is that mainly the problem is trigeminal. So if we stop that trigeminal ganglion by giving some destructive procedure that follows by stopping the pterygopalatine or trigeminal ganglion, so that could be a remedy of cluster headache. So that emphasizes the role of surgery. Okay, so we should know it. Another thing is that the neurostimulation therapy, we are going to have a discussion regarding that in our upcoming lectures. Okay, so this is cluster headache. Now, what is the paroxysmal hemicrania or hemicrania continua? We should always remember that these two are a bit rare in comparison to cluster headache. Okay, so there will be some manifestations. First manifestation, that all the headache that contains the term hemicrania, that must respond with endometasis. So if you get hemicrania, you should always remember that you must be treated with endometasis. There is a particular term that throws regarding these types of headache, that if a headache, we are suspecting that it is a headache of hemicrania continua or paroxysmal hemicrania, so that must be responded if we give endometasis. That is also a diagnostic criteria. Second thing is that if we consider the name, the paroxysmal hemicrania, that means transient hemicrania. Hemicrania continua, that means a continuous hemicrania. So there could be a strictly unilateral symptom. The first important thing is that because it is hemicrania, that involving one half of the headache, so that mimics the cluster one. But the second thing is that the duration must be small and the frequency must be increases in case of hemicrania paroxysmal. The duration must be small or must be lower in comparison to cluster headache, and the frequency must be increased in case of paroxysmal hemicrania. In regards of which? In comparison to cluster headache. In case of cluster headache, the duration must be longer and the frequency must be smaller and lower in comparison with paroxysmal hemicrania. Okay, so hemicrania continua, that means it will be a continuous headache. So if we check the classification criteria, there will be a severe headache that will be unilateral. Second thing is that the duration is very small, as you can see, 2 to 30 minutes. In case of cluster headache, it is at least 3 hours or 180 minutes. So the lowest variety of cluster headache is at least 15 minutes, which is almost the upper limit of paroxysmal hemicrania. And second thing is that in case of cluster headache, there will be one episode in 1 to 2 days. Okay, in the rarest time, it could be 7 to 8 episodes in a day, but it is rare. In the most of the cases, there will be 1 to 2 episodes in a day. But in paroxysmal hemicrania, there must be at least greater than 5 episodes. So it will be at least more than 5 episodes in a day. Sometimes it could be lasting for 5 to 50 episodes in a day or 20 episodes in a day. And there will be some autonomic features, as we said. So conjunctival ingestion, lacrimation, ptosis, meiosis, all these features will be there. And that will be stopped completely by giving indomethacin. So that is an important diagnostic criteria. If we check the difference between two sorts of headache, so as you can see that all this headache, this is paroxysmal hemicrania or hemicrania continua, that must be unilateral. So it is hemicrania. That is important part. Second thing is that this must be associated with autonomic features. So there could be autonomic features. Sometimes there could be migrainous feature as well. But important thing is that the duration and frequency, the two facts that will distinguish the paroxysmal hemicrania with migraine. Okay, so in case of paroxysmal hemicrania, the headache that usually lasts for approximately 2 to 3 minutes, in rare cases, it could extend up to 30 minutes. And the frequency, as we said, or sometimes can be up to 50 episodes. No, so we should remember it is a frequency could be at least 5 episodes to almost 40 to 50 episodes in a day. Okay, and the headache must be responded with endomethacin. If we talk regarding the hemicrania continua, so that will be unilateral. And second thing is that it will be persistent headache. So a persistent headache that is unilateral, sometimes is mild to moderate with the exacerbation without any resolve. That is the hemicrania continua. If a patient came to you complaining that he or she having persistent headache involving the right side of the head, okay, and there will be no remedy, it's continued headache. And sometimes all that episode that we give endomethacin, the headache particularly relieves, we should consider this is a hemicrania continua. Okay, if a patient came to us with having unilateral headache involving the temporal region, having some photophobia or having particularly conjunctival ingestion or having congestion or lacrimation or rhinorrhea, that headache with this autonomic symptom lasting to 2 to 3 minutes, having 20 episodes in a day, we should consider this is a paroxysmal hemicrania. So that must be responded with endomethacin. So we should remember. So we have discussed 3 important types. One is cluster, another 2 is paroxysmal hemicrania and hemicrania continua. Now, another 2 types. First is SUNT, second thing is SUNA. We should always remember, in case of short-lasting unilateral neuralgiform headache, they are strictly unilateral. The first criteria, that will be moderate to severe, that is none of our business. The most important fact is that the duration and the frequency. The duration, as we said that in case of cluster, the duration is 15 minutes to almost 3 hours. As I told you, the duration that will lasting for 15 minutes to almost 3 hours in case of cluster headache. If we study the paroxysmal hemicrania, the duration is almost 2 to 30 minutes. So cluster is almost hours. The paroxysmal hemicrania is almost some minutes. But if we study the SUNT and SUNA, the lasting duration will be some seconds. So it could be 1, 2. In the highest duration, it could be extending up to 600 seconds. Okay, so this is the headache of seconds. There will be some stabbing headache or some sore-throat pattern headache. The important thing is that the headache that will last with some seconds. Sometimes 1 to 3, 15, 20, 30, 40 seconds. In the highest cases, the highest recorded duration is 600 seconds. And the frequency, there could be infinity episode in a day. Okay, sometimes more than 60 in almost an hour. So that will be important fact if we want to consider the SUNT or SUNA. So the duration and the frequency, that is the 2 important fact that will distinguish with other sorts of headache. Okay, so the frequency, and that might be having ipsilateral cranial autonomic features, as I told earlier. So the majority cases, the headache will be precipitated by touching the face. So the headache that is typically precipitated by touching, that is another type of headache is trigeminal neuralgia. So that could be also precipitated by touching, or sometimes having brushing teeth or chewing food, or sometimes talking, even coughing can precipitate the headache. But according to the primary headache, trigeminal neuralgia, apart from trigeminal neuralgia is not an absolute primary headache. But regarding the trigeminal autonomic cephalgia, the sometimes sooner can be exacerbated by touching, mere touching the face. Okay, so that is important similarity of trigeminal neuralgia with Sang and Suna. But the two important thing that will distinguish Sang and Suna from trigeminal neuralgia, first of that is the presence of autonomic syndrome. In case of Sang and Suna, that will be positive. And second thing is that in case of, unlike trigeminal neuralgia, most of the patient in Sang and Suna having no refractory period. So these two things we should remember. So if we want to distinguish Sang and Suna on the basis of autonomic feature, so if you want to distinguish Sang and Suna on the basis of autonomic feature, we should check some symptom. If we are going to discuss or diagnose a case of Sang, so that will be having two important features. That is the conjunctival ingestion and lacrimation. As you can see, there is some conjunctival ingestion and sometimes there will be lacrimation. In case of Suna, there will be only one of these features or sometimes no features of conjunctival ingestion or lacrimation. So a patient approximately 40 years of age came to us with having particularly a headache that is strictly unilateral, lasting for approximately 20 seconds, occurring approximately 18 to 20 times in an hour. So in an hour, 18 to 20 times, each episode lasting for 20 seconds. The patient is having conjunctival ingestion and lacrimation, at least both. Then we can diagnose it as short-lasting unilateral neuralgia from headache with conjunctival ingestion and tearing, that is SUNT. If the patient having typical headache of strictly unilateral lasting for approximately 20 seconds and having 18 to 20 episodes per hour with no feature of conjunctival ingestion or lacrimation, or only one feature of conjunctival ingestion or lacrimation, we can say this is short-lasting unilateral neuralgiform headache with autonomic symptom. This is SUNA, not SUNT. So this is a very important thing we should remember. Now, so if we are getting these sorts of headache, we should need to exclude some differentials, particularly some secondary causes or trigeminal neuralgia. Like these are the things that needs imaging. Okay. So if the SUNT and SUNA are as a cause of primary headache, then we should not do any investigation. It is a clinical diagnosis. But if there is any feature compatible with secondary headache, particularly any focal symptom or any features of raised ICP, that will give us a clue regarding any intracranial space occupying lesion, we should check for any MRI or imaging. Okay. And sometimes the recent study, they have a great role. They said that the brain MRI sometimes determined a arterial loop that contacting the trigeminal nerve. So if we irritate the trigeminal nerve with some aberrant arterial loop, that can manifest two important things. One is trigeminal neuralgia, and sometimes it could be associated with SUNT and SUNA also. Okay, so the treatment. As we already discussed that in the most of the cases, the headache that lasting from only for some seconds. So we should not give any abortive treatment here. Okay, so a headache that lasting only some seconds, we are going to give some painkillers for that. That won't work, because in the most of the cases, headache would stop spontaneously. It will occur again, but it will stop spontaneously. So the first thing is that we need to give the preventive treatment. And the best drug for that is the lamotrigine. In case of cluster, the best drug for preventive treatment is verapamil. But in case of Sanctensuna, the best drug for prevention is lamotrigine. So that is important thing. So another thing is that trigeminal has a great role here. So sometimes trigeminal microvascular decompression is a particular useful thing you need to consider. Now, so if we check a classification or a table regarding the classification of tags, we can see that all these tags having stabbing headache. So stabbing or something jolting or boring or burning headache can be present in all sorts of tags. But the most important thing is that the hemicrania continua will be a continuous headache. Okay. Second thing is that in all of the headache, that will mostly involve the first division of the trigeminal nerve. So that will be the orbit and temple. As I told earlier, the trigeminal autonomic cephalgia, that will involve the first division of trigeminal nerve. But the trigeminal neuralgia will be involving the second and third division of the trigeminal nerve. So that is, you should remember. So all of those headaches will be involving orbit and temple. So orbit and temple. Okay. Next important thing is that attack frequency, attack duration, and the treatment. These are the three criteria how we can differentiate all these sorts of headache. First thing is that attack frequency. In case of cluster, it will occur in every alternate day. 2, sometimes in rare cases, 8 episodes in a day. Each episode must be lasting approximately 15 minutes to 3 hours, as I told earlier. Second thing is that if we want to consider partial hemicrania, the headache will be much more frequent than cluster ones. So it could be greater than 5 episodes in a day, and each episode will be some minutes, like 2 to 30 minutes. If we want to consider the Sanctensuna, there will be a very frequent headache, sometimes greater than 30 hours, each episode lasting for approximately 1 to 600 seconds. And hemicrania continua is a continuous headache. All of these headaches are trigeminal autonomic cephalgia. So all of those having a autonomic manifestations. Sometimes in cluster and hemicrania continua and paroxysmal hemicrania having some migrainous features like nausea, vomiting, photophobia, phonophobia. You should always remember alcohol can trigger a particular episode of cluster headache, and cutaneous trigger are more useful in Sanct and Suna. Endomethacin will only work with in episode of hemicrania continua and paroxysmal hemicrania of trigeminal autonomic cephalgia. These two headaches are endomethacin sensitive. All the other headache will not be as much sensitive with endomethacin. Okay, so in case of prophylactic, we should give verapamil to cluster and lamotrigine to all the headache of Sanct and Suna. And endomethacin will be particularly more useful in case of hemicrania continua and paroxysmal hemicrania. So we should always remember this fact. Now, let's wrap it up. As you can see, the frequency, as the time progresses, the frequency will be more and the duration will be smaller in case of cluster to paroxysmal to Sanct. So that is important thing. Okay, so alcohol and is a very good triggering factor for cluster headache. Okay, and cutaneous will be a very good triggering factor for short-lasting unilateral neuralgia from headache with conjunctival injection and tear. So if we summarize with a single chart, as you can see, in case of cluster headache, the frequency, as you can say, it will be almost 1 time in a day. Okay, but if we want to consider some other headache, particularly paroxysmal hemicrania, it could be sometimes 40 to 50 episodes in a day. In case of some, it could be 200 to 300 episodes in a day. So the cluster headache, the frequency will be smaller. In case of some, the frequency will be a lot higher. In case of duration, as you can say, the cluster headache, in case of migraine is the headache of some days. It can last for 4 to 72 hours. So it is the headache of days, not 1 day, days. The cluster headache is the headache of 1 day, particularly in the most of the time. So it have a headache of particular some hours. So migraine is the headache of some days. Cluster is the headache of some hours, particularly 2 to 3 hours. Paroxysmal hemicrania is the headache of some minutes. Sang or suna is the headache of some seconds. So these two facts will help you to distinguish all the type of trigeminal autonomic cephalgia if you want to discover. Okay. Now we can proceed to take some other primary headache. That will be a bit interesting one. That will be the primary cough headache that will be associated with cough, primary exercise headache, primary sex headache. We should remember that sometimes the headache that is exacerbated by cough is a feature of raised intracranial pressure. Headache that is exacerbated by exercise is a feature of raised intracranial pressure. But we need to exclude all sorts of secondary headache if we want to discover that a primary headache. So a patient came to you with having coughing, sneezing, straining, and the patient having headache at that time. So the patient having headache or severe headache at the time of coughing, sneezing, or straining with no features of secondary raised intracranial pressure headache. We can say that this is primary cough headache. Okay, so it takes a lot of things and a lot of guts to diagnose a headache with primary cough headache. Sometimes it could be bilateral posterior. We can treat that with endomethacin. They are very good in these sorts of headache. Second thing is that another headache that could be triggered by exercise with no features of secondary exercise headache, we can say it a primary exercise headache. It's a bilateral throbbing pain that can last from 5 minutes to 48 hours. Second thing is that we can treat this headache with endomethacin. The headache that is precipitated by masturbation or coitus, that is the primary sex headache. We can give easily propranolol in this sorts of headache syndrome. Another thing is that primary thunderclap headache. When we hear the name of thunderclap headache, we should always consider subarachnoid hemorrhage. It is our inbuilt tendency to think that it is subarachnoid hemorrhage. Actually, subarachnoid hemorrhage is one of the common cause of thunderclap headache, and that is justified. But the headache that is primary thunderclap headache, we can say it the headache that is start abruptly and reaches to most painful point within 1 minute. So patient will be having headache and he will say, I am facing the worst headache within 1 minute of the onset. So we can say primary thunderclap headache when we are excluding all the secondary causes like the subarachnoid hemorrhage, venous sinus thrombosis, arterial dissection, the Press syndrome, that is a posterior reversible cerebral encephalitis syndrome, or acute cerebral ischemia. Sometimes you should always remember it is almost impossible to distinguish the primary and secondary thunderclap headache on just clinical ground. Okay, so we need also imaging in order to confirm that whether it is primary thunderclap or as a consequence of secondary thunderclap headache. So primary headache, stabbing headache is a very interesting one. It is having sometimes transient sharp jabbing pain that occurs some localized area of the skull, particularly in the trigeminal division. So this is a primary stabbing headache. It could be unifocal or multifocal. It will last approximately some seconds. Most of the cases, it will be responded with endomethacin. Nubular headache, it is an epileptical and particularly coin-shaped area of headache. So it is epileptical, that is the elliptical or sometimes coin-shaped. That is an important term we should remember. It is a circumscribed area of pain in the head. Okay, so we can give gabapentin to all sorts of nubular headache syndrome. Now, another very interesting one, patient will come to you and say that, okay, I'm sleeping and sometimes I wake up due to severe headache. Okay, and the headache that lasting only the time when I sleep, and after sleep it tends to get increases and worsened, and at a point it will be so severe that I need to wake up. So headache is working just like an alarm clock. So we can say this is an alarm clock headache, and it occurs and lasting typical to cluster headache for 15 minutes to 3 hours. Sometimes the patient having some migrainous feature like nausea, vomiting, photophobia, or with autonomic features. And the headache, particularly in case of duration or in case of presentation, can mimic cluster headache. But important thing is that the headache, that is the cluster headache, actually will not occur during the time you are sleeping. Okay, and the alarm clock headache or hypnic headache typically occur at the time of sleeping. So another thing is that the headache particularly occurs after the age of 50 years. So we should always remember this thing as well. Another thing is that the new persistent headache syndrome or new daily persistent headache. So it could be any type. It could be migraine, it could be tension type headache, or it could be other secondary headache as well. The headache that is the new daily persistent that will persist approximately 24 hours of onset, and it is daily headache, can persist for more than 3 months. And in the most of the cases, the headache, the patient will certainly particularly say that I am having this headache for suppose the 15th January. He can say the exact date of the headache. So this is an important clue. Okay, you can think it could be a new daily persisting headache or persistent headache. So as you can see, the migraine would be a cause of persistent headache. Okay, and sometimes featureless headache like the tension type headache is also a type of new daily persisting headache syndrome. And sometimes the secondary cause as well important. So that's it from today. In the next class, we are going to start from the secondary headache syndrome, like the trigeminal neuralgia. That is actually, we are not putting that in a primary headache syndrome. We are going to have some other interesting headache as well. We are going to have the headache of raised intracranial pressure. We are going to having the benign intracranial hypertensions. A lot of secondary headache will be discussed. Okay, so till now, it's goodbye. And let me know in the comment section which thing you need to recapitulate or which thing you need to have a more understanding on, and let me know your feedbacks on the comment section as well. So thank you so much for today's lecture.